The following episode contains depictions of domestic violence that some listeners may find disturbing. Listener discretion is advised.
Hello, and welcome to the RSNA Radiographics Podcast. My name is Jennifer Weaver, and I'm a musculoskeletal radiologist at the University of Texas, San Antonio. I am here with Jonathan Revels, a chest and body imager in the Department of Radiology at NYU. Our episode today is being recorded at the RSNA 2024 meeting in Chicago, Illinois.
Our guest for today's podcast is Dr. Jamie Elifritz, a forensic radiologist and a co-author of Postmortem Computed Tomography, Applications in Clinical and Forensic Medicine. Dr. Elifritz, welcome. So how exactly did you get involved in forensic imaging?
Thank you. It's a pleasure to be here. First, I would like to thank my co-authors. I would especially like to recognize Dr. Nadia Solomon, who is the first author and is currently undergoing a customized forensic imaging fellowship at Yale. I was fortunate to be introduced to postmortem imaging early in my radiology residency at the University of South Alabama by my mentor, Dr. Gil Brogdon. He is known as the father of forensic radiology. I was hooked from the first case that he shared with me, which was a radiologic identification case. During residency, Dr. Brogdon and I worked together on many projects, and he encouraged me to design a dual musculoskeletal and forensic imaging fellowship. For my forensic imaging fellowship, I worked closely with experienced forensic pathologists and radiologists. I trained in Maryland at the Office of the Chief Medical Examiner, and I trained in Albuquerque at the Office of the Medical Investigator. I had dual appointments with the departments of radiology and pathology, and I provided forensic imaging education at the OMI in Albuquerque for 12 years. I contributed to daily service work involving assisting in the morgue and providing in-person radiologic pathologic correlation, and I collaborated on numerous research projects, including multiple NIJ and NIH grants. Currently, I'm the Chief Medical Officer of a forensic imaging group.
This is such an interesting and important part of imaging, but one that many radiologists don't know anything or very little about. Can you tell us more about postmortem investigation and the role of postmortem CT?
I'd love to. When we talk about postmortem investigations, we should first define a few terms. Autopsy refers to the postmortem examination of a human body to determine cause of death. There are multiple components and models for autopsy. Classically, it is described in reference to the external and internal exam. The external exam is completed on an intact body to provide detailed documentation of the remains. Traditionally, body diagrams and photographs are obtained. A full or complete autopsy involves both the external examination and the internal examination. The internal examination is performed by a forensic pathologist who opens the body and dissects the body cavities, organs, neck, and brain. When any part of a full autopsy is foregone, the process is referred to as a partial autopsy. Postmortem CT is an extensively studied and widely utilized modality for postmortem imaging examinations. Like clinical imaging, it allows us to non-invasively acquire diagnostic information about the internal structures. Postmortem CT can supplement and, in select cases, supplant full autopsy.
Wow. So how does one perform postmortem imaging? Are there special protocols here?
There are. First, you have to understand the differences in the goals of clinical imaging and postmortem imaging. In clinical imaging, we diagnose with the intent to treat when possible. In postmortem imaging, again, our main goal is to determine the cause of death. However, we also serve the families of the deceased by providing important medical information about their loved ones. In postmortem imaging, it is best practice to scan the entire body, including the extremities, so that no important findings are missed that could help determine the cause of death. Unlike clinical imaging, we are not concerned about radiation exposure to the body, so we can turn up the juice, so to say, to optimize imaging quality. Like clinical imaging, it is ideal to have thin slices for high-resolution source images and multiplanar reconstructions. The International Society of Forensic Imaging has developed some excellent guidelines for postmortem imaging protocols. Also, there is a great table included in our radiographics article that highlights PMCT protocols from the literature.
So, what are the clinical indications? How does one decide when to perform these studies?
All medical legal cases can benefit from postmortem CT. Some of the most common applications include traumatic deaths like blunt force trauma, gunshot wounds, and sharp force injuries. In fact, PMCT is superior to autopsy for detecting the extent of skeletal trauma and is excellent at recreating mechanisms of injury. Natural death investigations are enhanced by postmortem CT, and many of these cases would otherwise be excluded from autopsy based on age and medical history criteria. In many cases, imaging can provide a precise cause of death, like in the context of an acute abdominal aortic rupture. This information helps the family understand why their loved one has died and provides an accurate cause of death for the death certificate. Postmortem CT can be instrumental for identifying unknown remains and can differentiate thermal from non-thermal injuries in the case of charred remains. The modeling appearance of bone marrow can even provide information about the direction of the fire. Given the legal implications of these investigations, what the PMCT scan can rule out can be just as powerful as the pathology it can detect. For example, we can exclude internal injuries, which is the main question in cases of older decedents who are often found down on the floor in their homes, and the investigator needs to rule out foul play. Similarly, we can exclude internal trauma in individuals who have died from an overdose, and these are two very common scenarios.
Can you give us some examples of the use of postmortem CT in death investigations?
Certainly, what first comes to mind is what a game changer postmortem CT was during the COVID pandemic. We were overburdened with cases and had limited resources, including testing kits. Postmortem CT allowed us to triage our cases and save our limited RT-PCR swabs for decedents with compelling lung findings. This increased our pretest probability for testing for COVID-positive individuals, and it gave our forensic pathologist a heads up before opening the body. I had a case of a 38-year-old male who was witnessed to fall off his motorcycle at a low speed as he was approaching a stop sign. He had no known medical history, his toxicology was negative, and he had an unremarkable external examination. On CT, he had a Jefferson fracture and a type 2 Dens fracture. The fractures were minimally displaced, and this location is not often dissected at autopsy, so postmortem CT was crucial to providing a timely and definitive cause of death. Another memorable case was a woman who was a victim of domestic violence. At external exam, she had many contusions, and stretch marks were evident around her mouth grossly. The postmortem CT demonstrated an ovoid radiodense foreign body in her oropharynx. Identifying this finding during triage helped guide the autopsy, where a large avocado pit was removed. Additionally, imaging provided unaltered documentation of this trauma that could be used as a demonstrative aid for legal evidence.
What is the zero status of the body? Also, can postmortem CT be used to triage decedents?
Zero status is a very nice term. Autopsy, by its nature, is a destructive process. Organs are removed and tissue is sent for histology. Postmortem CT allows us to non-invasively visualize and document the body. Just like I mentioned, postmortem CT can identify foreign bodies in situ, including medical devices, bullets, knife tips, and even an avocado pit. This information allows us to understand and educate when medical devices are misplaced, like in esophageal intubation, and can recreate the mechanism of injury, like in cases of blunt force trauma or gunshot wounds. The zero status can identify findings that may be hazardous to those performing the autopsy, like sharps, explosives, and communicable diseases like tuberculosis. Postmortem CT images provide enduring documentation of the body for demonstrative aids and future review. And yes, it's a wonderful tool for triaging cases.
So can postmortem CT help in decedent identification?
Yes, PMCT is the most common modality for comparing antemortem imaging to postmortem imaging for radiologic identification. Postmortem CT can be compared to any other antemortem imaging studies. We can apply biometric data and known standards to help establish age, sex, stature, and ethnicity while working closely with our forensic anthropologist colleagues. Postmortem imaging can be used in facial reconstruction, and these applications can be particularly helpful in the setting of advanced decomposition. When we have a presumptive match for our unknown decedent, The postmortem CT is compared to any and all antemortem imaging that we can get our hands on. We compare normal anatomy, anatomic variants, known prior trauma or surgery, and known natural disease. And of course, it's most important to identify the correct person. So being able to acknowledge when you do not have enough information or being able to rule out a presumptive wrong match are both very vital skills. Protocols have been devised for identifying unknown remains and disaster victim identification, including mass fatality events. I recommend anyone who is interested in learning more about mass disaster victim identification protocols to visit the International Society of Forensic Imaging website for reference.
These are all very interesting applications. How accurate is postmortem imaging?
That's a great question. Postmortem CT is more accurate than autopsy for skeletal findings. This is most helpful in regions of the body where autopsy is challenging and may not be routinely examined, like the cervical spine and the pelvis. Postmortem CT also excels at finding gas collections. The process for identifying pneumothorax at autopsy is cumbersome and includes opening the chest underwater and watching for air bubbles, whereas pneumothorax and even more subtle pathologic gas collections are easily identified on postmortem CT. However, PMCT is less sensitive for many soft tissue findings, especially for superficial injuries, including bruises and burns. A prospective validation study by Elifritz et al. Determined that postmortem CT and autopsy, while both imperfect, were comparatively sensitive for injury detection, and that postmortem CT findings can sufficiently establish cause of death in blunt force injuries, firearm injuries, drug poisoning deaths, and pediatric trauma. They found the sensitivities for recognizing pathology among autopsy reports and radiology reports were similar. The overall sensitivity for autopsy was 74.6% versus 71% for postmortem CT. For the most optimum evaluation, they recommended that both PMCT and autopsy should be combined.
So, Dr. Elifritz, what do you see as the biggest benefits of postmortem imaging? And on the flip side of that, what do you find to be the biggest limitations?
I think the greatest benefit is aiding our medical legal death investigators. There's a global forensic pathologist shortage, and the U.S. has less than a third of the practicing forensic pathologists that are needed. The number of autopsies continues to decline. In the 1950s, the autopsy rate was around 50%, and it's less than 5% now. Death certificates are the primary source for mortality data, and these vital statistics inform us about trends in human health and healthcare. The lack of autopsies leads to unreliable epidemiologic statistics. Postmortem CT can provide powerful internal information about the body that, when combined with an external examination and a comprehensive investigation, can help our forensic pathologists do their jobs more efficiently with reduced costs. Also, in some instances, it allows us to respect religious and cultural objections to autopsy while still providing necessary medical information. There is a huge benefit for stakeholders, including families, communities, and government agencies. I think the biggest limitation is the lack of forensic imaging education. Postmortem CT is a powerful tool, but the accuracy of the report relies on the education and experience of the interpreter. Confounding postmortem change for pathology or vice versa will result in diagnostic errors. Similarly, a lack of fundamental CT interpretation skills will lead to inaccurate reporting. These pitfalls may ultimately lead to ascertaining the wrong cause of death. Education is required at all levels for meaningful and responsible adoption of postmortem CT in medical legal investigations. Anyone ordering a postmortem CT needs to understand the limitations of non-enhanced studies. Most importantly, they need to understand the limited sensitivity and specificity for many soft tissue findings and acknowledge how postmortem changes affect interpretation. This knowledge supports reasonable expectations and responsible use.
I imagine that interpreting postmortem CT has many differences from our typical imaging of living patients. Can you talk to us about some of the expected changes you see on these studies?
Yes, there is a learning curve for interpreting postmortem changes. The most common changes evident on PMCT are LIVR, related to cessation of blood flow and gravitational effects, putrefaction, which is gas production, and autolysis, the breakdown of cells and tissues, which leads to liquefaction. One of the first steps of PMCT interpretation is gauging the degree of decomposition. This skill must be mastered to avoid overcalling or undercalling pathology. Some of the most striking postmortem changes occur in the vascular and pulmonary systems secondary to liver. In the chest, the cardiac chambers and great vessels often demonstrate a hematocrit effect from hypostasis and sedimentation. The pulmonary arteries commonly demonstrate postmortem clot that can mimic a pulmonary embolism. The lungs will variably demonstrate lividity with a ground glass density dependent gradient that can be challenging to differentiate from underlying pathology. Those new to postmortem imaging may not expect to see fluid in the airways, which is present 50% of the time and is related to agonal aspiration. Postmortem fluid also commonly accumulates in the sinuses. It can be challenging to discriminate postmortem from pathologic gas. There are common patterns to look for, like gas is first identified in the right heart and portal veins. However, the spectrum of pathologic and expected findings is wide and depends on environmental factors and the health status of the decedent. Of course, gas patterns from pathology and decomposition can and do occur in the same body.
So, Dr. Elifritz, in general, what do you see on the horizon of forensic imaging as a whole?
I see widespread adoption of postmortem CT in the United States. For this to happen successfully, we need buy-in from forensic pathology fellowships and radiology training centers. Fundamental forensic imaging skills need to be incorporated into these programs. It is well established that forensic pathologists and radiologists' reports are synergistic, leading to the best understanding of the cause of death. Working together, we can revolutionize the system of medical legal death investigation in the U.S., providing the highest level of care for our decedents and their families, supporting our legal system with the best evidence, and contributing the most meaningful data to vital statistics for future healthcare innovations.
This has been a fascinating look into imaging after death. Thank you, Dr. Elifritz, and also your co-authors for this very interesting review. I encourage everyone to check out their many interesting images online. Thanks for joining us today.
Thanks so much.
Thank you.